I'm really excited to give this talk, especially because yesterday we held a workshop on mathematical modeling. So I think especially for those who were at that workshop, this will be a really interesting way to see how you can use these models. And for everyone else who knows very little about mathematical modeling, it's still a very interesting, substantive issue. One which would be difficult to answer, a question which would be difficult to answer without some type of modeling like this, and I'll explain that a little more as we go. I should first say this is a collaborative project with Timothy Menzer, who was a student at the time, Stephen Goodrow, who was here yesterday with the modeling workshop and has been a mentor of mine for a while, and Matthew Golden, who is currently the director of the HIV/AIDS division at the Seattle Public Health Seattle and King County. So this project actually came out of a collaboration that an ongoing collaboration that we have with the University of Washington and the Health Department in Seattle. Okay, so I'll get started. So when Steve and I were initially talking about this question, he said, you should really start with asking the audience this hypothetical question. Say you're looking to have a one-night stand with somebody and you're HIV negative. All else is equal between Pat and Jamie. Would you choose Pat, who you don't know his or her HIV status, or Jamie, who claims to be HIV negative? For me, of course, I would choose Jamie, right, if all else was equal. But a few recent studies that motivated our study suggested that actually you should probably choose Pat, which made no sense to me at the time until I started thinking a little bit more about it. And it has to do with a couple of things, which I'll get into more later, but mostly it has to do with the prevalence of men who are actually HIV positive but undiagnosed and think that they're negative. So that's kind of the punchline. So serosorting, in the broadest sense, is partners making decisions based on their assumed or perceived HIV status and their partner's assumed or perceived HIV status. So it can really be negative with negative or positive with positive. We'll focus, since we're thinking about HIV prevention, primary prevention, we'll be focusing on negative with negative. But the trick is that serosorting is based on the perceived status, whereas the bug, transmission of HIV depends on actual status. So that's the disjoint that makes this a really interesting question. So as I mentioned, there were two papers that kind of motivated our paper. One suggested that serosorting is actually detrimental prevention strategy because of the high viremia during the acute stage of HIV. And I have a few slides later that will talk more about this, but essentially when someone first becomes infected with HIV, they are more infectious to others. They're more likely to spread the disease. And the other paper suggested that when there's low rates of testing or there's a high population among HIV positive men who don't know that they're positive, then the serosorting can be risky as well. So this has to do with people unaware of their infection, which is also a function of infrequent testing, or testing too early where you actually get a false negative test, or for people who are undisclosed or disclosed falsely. So those are the two papers. And then let me back up and just motivate why this is an interesting question. HIV in the United States, the most recent CDC estimates were from 2006, so they're a few years old now. But they predicted there were about 56,000 new infections during the year. And among all the infections, men and women, men who had sex with men, and bisexual men represented more than half of those infections. When you look simply at HIV infection among men who have sex with men represent more like 3/4 of the infections. So men who have sex with men disproportionately suffer from HIV in the US. That's just a simple fact. Recent surveillance also has showed, in Seattle it's a little different, but nationally there's been a slight increase in the number of HIV diagnoses for MSM. And some people suggested that that has to do with increases in unprotected sex acts with people whose serostatus is unknown. There's a lot of other research about behavior once people are diagnosed with HIV, but I won't get into that at the moment. And this particular study uses data from Seattle, Washington. In the epidemic in Seattle, in white MSM in Seattle, prevalence is about 12%. So 12 out of 100 MSM in Seattle are infected with HIV. And about 10 to 20% of those men are thought to be undiagnosed, so they don't know they're actually infected. You know, this, I also am not going to get into race and ethnic differences in HIV, but in many other cities around the US, prevalence among MSM is much higher, and among African American MSM, in some places it's more like 40 to 50%, so it's really, really a problem. Okay, so serosorting. Serosorting has been a recent hot topic among academics, but it's nothing new for men who have sex with men. Men have been using condoms more often with partners of discordant status, so when they know they're negative and someone is positive, that's a type of serosorting, and both positive and negative men are more likely to have sex with partners of the same status. So this has been going on for a while. The academics have just kind of picked it up recently. But in the public health world, it's been kind of a controversial issue as to whether it's a good prevention strategy or not. Most epidemiologic studies suggest that it offers partial protection, but as I mentioned, these two modeling studies suggested otherwise. And for those reasons that I mentioned, high viremia during the acute stage and the high prevalence of undiagnosed infections. So that's why we decided to do a more in-depth model, to use actual data from Seattle in our model to try to answer the question in our paper. Well, I should say the second model came out at the same time ours did, so I'll get to that. I'll get to that later. Okay, so the aims of this talk and of this paper are twofold. One is to evaluate the population and individual level effects of serosorting among MSM in Seattle. So this paper really focuses on just our Seattle epidemic. And secondly, to define factors that might influence how these serosorting affects HIV transmission dynamics. So for those who were in the modeling class yesterday, the first is a mathematical model, and the second is basically a sensitivity analysis within the model. I always like talks where you get to know the result at the beginning so you can think through it. And the results of our model is this: serosorting in the context of men who have sex with men in Seattle, where they test frequently, serosorting is a protective strategy. But if you look at our model and think about rates of testing in other cities, it seems that that would definitely not be the case in other cities where rates of testing are not as frequent. So serosorting can be protective if men test frequently. Therefore, the recognition of serosorting's importance should prompt more frequent testing and more sensitive assays. Tests that pick up the infection earlier, basically. Okay, one last thing before we start getting into the paper is often when you read about serosorting in the literature, people kind of combine the definition of serosorting as having unprotected anal sex with a partner of the concordant status. But that kind of mixes a couple of issues together. So we try to separate them. And when I say serosorting, I'm simply referring to the use of serostatus in selecting to have anal sex or a sex act with that partner. But then we also separately look at status-based condom use, which is the differential adoption of whether or not to use condoms by your partner's perceived status. Okay. I already said that, so we keep them separate. Okay, I should say if you guys have questions in the middle, please let me know, because I want to make sure that the methods are clear so that you can understand what I'm assuming and what assumptions I'm putting into the model. So the methods that we use, since we want to know the population level effects of individual level behavior, it's hard to really empirically measure that. So we use a model to try to simulate it. We decided to use a deterministic continuous time mathematical model of HIV transmission. And basically we build a hypothetical cohort of men, and we separate them into compartments where they have similar characteristics in those compartments. And then we identify a set of differential equations that determine the size of each compartment. So basically, how often men become infected, how often they decide to get tested, how often they adopt treatment, etc. The compartments that we think are important for this population are the following. Stage of HIV disease, and that's because we know that infectiousness is higher early on. Testing, or the true knowledge of HIV status, that's a central characteristic for our model, since we want to know men who are actually positive but disclose as negative. Antiretroviral treatment, this is especially important now since we know that treatment really can be used as prevention for people who are adherent to their antiretroviral treatment. They're much less infectious to others. So antiretroviral treatment is both good for the HIV positive individual, but also for population level prevention. And lastly, sexual activity level, and this was defined by the data that we used in Seattle. We divide them into men who, well actually there's 3 categories: men who didn't have any anal sex partners in the last year at all, men who had on average 1 partner in the last year, and everyone else, and everyone else basically had on average 10 partners in the last year. And that's actually a lot lower than it's lower than some other models have assumed, and I think our data is actually correct. So, okay, this is kind of a messy slide, but it's really informative. So this is time on the x-axis, and depending on what we're looking at, the y-axis is either CD4 cell counts, it's HIV RNA, so this is actually the virus. And notice that the x-axis isn't quite continuous. It's weeks, 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 and then there's a break. And then this is years. So we know that viral load changes dramatically over time, as does infectiousness. So when someone first becomes infected, these round dots are virus. The virus peaks, and then your body kind of gets a little bit of a handle of it and can suppress the virus for a while. And we call this the acute stage of disease. When the body suppresses the virus, this 8 or so years, without treatment, is called the chronic stage. And then once the body is getting tired of all the fighting that they're doing, virus starts to creep up again, and this is called the AIDS stage of disease. At the same time, your CD4 cells, or the cells that are targeted by the virus, people without HIV have a high level of CD4. The HIV virus starts to attack those cells, but then the body rebounds a little bit, and then over time, without treatment, your CD4 cell counts begin to drop. But so this is really an important time to consider, the acute stage. Although it's really difficult to get a good empirical estimate of the probability of HIV transmission per sex act, for many reasons, it's hard to clearly get those data. The one paper that has done this, which is actually a bit old now, comes from a heterosexual study of African men and women. And they basically showed that during the first 5 months after somebody became infected, their probability of transmitting HIV to their partner is much higher than during the the chronic stage. So acute stage is higher, about 8 to 10 times higher than it is during the chronic stage. And then when virus starts to increase again, so does the probability of transmission. Okay. Testing. So in Seattle, well, first let me say, we in the model assume that the acute stage lasts about 3 months or 90 days. But there are different types of tests that you can use to see whether someone's HIV infected. Most health departments use what we call antibody testing, or EIA testing, enzyme immunoassay testing. And these tests search for the antibody in the blood. So you can only detect this once the body has already produced enough antibodies to be detectable. And that usually takes 7 weeks or so. So if this is your only test, somebody who gets infected and tests anywhere between here with this test will get a false negative test, even though they're actually positive. In Seattle, they've started doing pooled RNA testing, which actually tests for the virus. It's much more expensive, but it's much more sensitive. So somebody who is only a week or two, in our model we assume a week, but someone a week or two into the infection will actually get a positive test. So I include both of these in the model. Lastly, I think before I introduce the structure of the model, I wanted to talk a bit about antiretroviral therapy. So we know the use of especially highly active antiretroviral therapy is very efficient in suppressing the virus and stopping the progression of disease. So parameters, actually I should probably change this since I wrote this slide. Parameters have changed as to when you start your antiretroviral therapy. Actually, you guys probably already know all this, but basically, it usually starts when people have their CD4 counts around 350. So in terms of HIV transmission dynamics, not only in terms of the person who is HIV positive, but in terms of population level transmission dynamics, ART does two things. First, it extends the duration of infectiousness. So instead of being without treatment, someone lives on average 10, 12 years. Instead of being infectious for only that period of time, they're infectious for however long they live. But they are less infectious. There's a study specifically among men who have sex with men that suggests that men on antiretroviral therapy reduces infectiousness by 60%. However, some more recent studies suggest that people that are heterosexuals adherent to antiretroviral therapy reduces infectiousness by more, like to 80 to 100%. Yeah.
The decrease is that directional? You know, though, in other words, male to female is decreased 80 to 100%, or female to male? I was just wondering.
That's a good question. I think they do.
Direction to that.
I'm thinking of Connie Callum's recent paper, Deborah Donnell and Connie Callum, and they do report it by sex, who's the infected partner.
Yeah.
I don't think it varied that much, but I don't have the numbers in front of me. I think it was, for those that were actually adherent, it was 90%.
And in the men who have sex with men, you know, the top versus bottom also is sort of lumped together.
It is lumped. I think this estimate has them lumped together, but that's a really good question. Okay, so this is the model. We talked about compartments yesterday. This is 12 compartments, although here I'm only showing the low activity men. There are 12 compartments for low activity men and 12 compartments for high sexual activity men. The first row is the stage of disease. So men, I didn't put births and deaths here, but imagine that people can birth into the susceptible box, and at any point, people can die out of any of these boxes. But this is the typical flow that people can that can age through the model. So men are born susceptible, and they're true negatives. They become infected through the lambda, so this is a really important parameter right here. This compartment is, the U, the E, and the Y are the early and acute stage. This compartment represents men who are infected, but no tests can pick up their infection, neither the RNA or the antibody tests. Men in this stage are HIV positive, but only the RNA test can pick them up. And men in this stage are in the acute stage of HIV positive, and the antibody test can pick them up. That's why in either of these stages, they can get tested for HIV. If they don't get tested, they have HIV in the acute stage, undiagnosed, they're chronically infected, undiagnosed, and then they're in the AIDS stage, undiagnosed, untested, untreated. However, if they take a test, they can come down to this row. These are all the men who are tested but not yet on treatment, in the acute stage, in the chronic stage, and in the AIDS stage. Additionally, men can start antiretroviral therapy and would go down to this final row. These are men in the chronic stage. So we assume men in the acute stage don't go on treatment. Men in the chronic stage and the AIDS stage can be on treatment. So the important part of this figure are the colors. These are the only men who are true negatives. However, all of these men are apparent negatives. So when they disclose their HIV status, they say they're negative, although all of these men are positive. All of these men are diagnosed positive and disclosed as positive. However, all of these men are positive. So that's kind of the key to this model. Yeah?
Sorry, you said you didn't show birth, but do you just use birth as replacement for their death, or how do you?
The rates of birth and death are the same. So eventually this model reaches an equilibrium.
Okay.
Yeah, good question. Yeah.
Sorry, and do you distinguish between uninfected people who don't know their status and uninfected people who do know their status?
And disclose dishonestly?
No, who just know that they're negative versus they don't know that they're, I mean, the blue box is everyone who's negative.
Oh, for the negatives.
But like another row that's like, I'm
Right.
negative, and I know I'm negative.
Right. Maybe, yeah. No, we don't. We don't. So that would be interesting to think about how that would change
And they
change
kind
the
of
results.
cycle back, like
Right.
that lasts for a year or 6 months or something.
Right.
before they-
Right. And yeah, so this is a subtle point that we wrote in the paper but not in the topic. In our data, we have men that report as unknown. What we do with those men, but in our calculation of serosorting, we either put men into apparent negatives or apparent positives. So with those unknowns, we distribute them weighted by the actual prevalence in the population. So if there were 10% of unknowns out of 100, and there was 12% HIV prevalence in the population, 1.2 of them would go into the positive box, and the rest would go into the negative box. Yeah.
Susie, I'm sorry, this is so interesting, but when you say birth and death are equal, I was just thinking birth would be sort of sexual debut,
Yes.
And the death rate for treated gay men in the Seattle area, I would assume, would not be terribly high. So
Oops.
you said that you treat them as equal nonetheless?
Well, so when I say treat them as equal, I misspoke.
Okay.
Death rates are different depending on their HIV status. Death rates are different depending on if they're treated or not. But if you take all of the death rates together and you average them, that is equal to the rate of people entering, which is actually sexual debut. So if you run this model for 100 years, because those two rates on average are equal, the prevalence reaches equilibrium.
Thank you.
Okay, thanks for the questions. This is really, I think, helpful. Okay. So as I said, that this lambda is really the heart of this whole model. And HIV transmission is a function in our model of anal sex with a true positive. And this is a function of the contact rate, the number of partners that someone has per year, the number of anal sex acts within a partnership. We don't model any oral sex acts. The condom use within the partnership in the sex act, and the position, top or bottom. For the serosorting, the fraction of apparent negatives who are actually positives, that's really important, and the level of serosorting, which I'll show you the data in a second. So how often a negative man chooses another negative man as opposed to a positive man. Yeah.
So, in this model, do you distinguish between the receiver and the giver in anal sex?
Yeah,
Or-
absolutely. That's what I mean by position. Yeah, seroposition.
Okay.
Yeah, so the probability of transmission depends significantly whether they're receptive or insertive. And we have data on that as a function of serostatus as well. So that's all in there. A lot of the data, I don't give you the actual estimates, but if you're interested in building your own model of HIV and you need to know some of the assumptions that I use, you can go to the paper, and there's also a whole supplementary appendix that you can look at that has all of the data. Okay, and the data, although it's a small sample, we're really proud that this model is driven by data. We don't pull things out of the air. And the data come from men in Seattle from a random digit dial. If you know anything about sampling, you probably think random digit dials have their problems, and they definitely do. But this was 8 years ago, and I guess one benefit is that cell phones weren't as popular 8 years ago as they are now. I don't think you could really do it now at all. But we have some good data that we use. And here's the kind of the star of the show. The odds of serosorting for low activity respondents is 68 times. The odds is 68, and the odds for high activity men is lower, but still significantly higher than 1. So this means that the odds of a low activity positive man is 68 times more likely to choose a positive partner than a positive man is to choose a negative partner. So that's what that means. Okay, other data, as I just mentioned, I'm not going to go into the details, but they're in the paper if you'd like to know some of our point estimates for these others. Okay, and a reminder that we separate serosorting with the status-based condom use. And so let's get into some findings, if there's no other questions. Yeah?
A question about your Seattle population.
Uh-huh.
You mentioned that Seattle has a higher testing rate.
Mm-hmm.
And then what do you attribute that to in comparison to the rest of the country?
I'll be going out on a limb because I'm not an expert in this, but I think our public health department has done a good job with not only promoting testing, but promoting the early kind of testing, the RNA testing. I know that socioeconomic status is highly associated with testing, and there's major differences between the MSM population in Seattle compared to Baltimore. Do you see?
I can address that
Sure.
a little because I worked with this data and worked for the health department and the AIDS unit. And but you're right, there's much greater socioeconomic equity in Seattle. You don't have the division of wealth that you have in other cities. But another part of it is a lot of the testing targets came in Seattle, largely because of the West Coast. There's HIV, the difference between burden of disease and among MSM and other folks is much greater among MSM on the West Coast. A lot of local funds go into testing, targeting gay men, and they do community-based testing as well. There's a storefront on Pine Street where you can, in the heart of the gay neighborhood, where you can just go and get tested by other gay men for HIV and other STIs.
For free.
For free.
Mm-hmm.
So they deal with the problem as well as they have the resources.
Thank you. Yeah. Okay. So as I mentioned, I want to look at the population level and the individual level. Here's the population level. So so basically I run this model 2 times. I run it with serosorting equal to 1, and then I run it with the odds of serosorting equal to what we see in the data. When you run it with the data-driven model of the serosorting equals to 68 and 12, prevalence levels out at 16%, which is close to what you see in Seattle. Everything else equal, you take away the effective serosorting, prevalence goes up to about 24%. So this suggests that HIV prevalence would be higher if men did not serosort. Similarly, at the individual level, if you randomly choose a man to have unprotected anal sex with, who you think is negative, since some of them are positive, you'll have a risk of actually acquiring the disease. So this is unprotected receptive anal intercourse, and this is unprotected insertive anal intercourse. If men are serosorting, you still have a risk greater than 0 of acquiring HIV if you have sex with unprotected sex with a parent negative, but that's twice as high as if there is no serosorting. Same thing, it's about twice as high for the risk of unprotected insertive anal sex without serosorting. So in Seattle, both at the population and individual level, serosorting seems to be a protective strategy. The unintuitive result that came out of this model was that even though it's a protective strategy in Seattle, the proportion of infections that stem from undiagnosed men is higher when men serosort than when they don't. Same with the proportion of recently infected men. So that was really interesting. This also leads you to say serosorting may not be a great prevention strategy on its own. It really should be coupled with testing, because you still get a huge amount of infections stemming from men who are undiagnosed. And this is so high because of the acute stage of disease that is high. So the 30% of infections stem from newly infected, undiagnosed men.
Sorry,
Yeah.
Susie, can you go back one slide for a second?
Uh-huh.
So is this just a denominator effect? It's not, I mean, the proportion is higher, but the absolute number, because the overall number of infections is lower with serosorting.
Are you talking about this one or this one?
On the one on the left, so you
Uh-huh.
have the overall, I mean, the overall number of infections is lower if you have serosorting. So if you go forward, so then
Oh, I see what you're saying.
I mean, it might just be because it's a denominator effect, right?
It might be, yeah.
That you can look at the instead of the proportion of infections, the number of infections
Right.
by undiagnosed men. And
Right.
You might see the reverse.
Right. Absolutely. You're right.
But
But
it's still,
it's still, yeah, right. Even though it's fewer infections overall, it may, right. That's a good point.
Can I ask something?
Yeah.
I may have missed this, but you get de facto serosorting by assignment mixing by age.
Okay, we don't include that in the model,
Okay. So
Yeah.
this is right on.
which is a good question given what we talked about yesterday. If I included age as well, it would make this model even more difficult. Right. Okay, so now let's talk about some of the sensitivity analysis. This is where I look at contact rate. So the x-axis here is the mean anal sex contact formation rate, or basically the number of partners per year. Remember that I mentioned there are two populations I keep track of: the low activity people that have one partner on average, and those that have 10 partners on average. When you weight them all together, the average is about 3.7 partners per year. And this line represents kind of the baseline scenario. Okay, so the reason why I circled this is because this is the baseline scenario with serosorting. Prevalence is 16%. All else equal, you take away serosorting, prevalence goes up to 24%. That's what I showed you in the previous slide. However, if you start to say, okay, what happens if men start having more and more and more sex partners? You see that once they have about 7 partners on average per year, the advantage disappears. Exactly. These lines cross. So another way to think about it is serosorting is more or less equivalent to an 86% increase in the number of partners, the protective effect. Or you see the same effect if you decrease the number of partners, you see the same effect as if you didn't have serosorting. That's another way to think about it. And this is with the baseline rates of condom use that we see in the model. But what about if men didn't use condoms? Because a lot of people think of serosorting as a prevention strategy in place of using condoms. So what if people serosorted at the rates they told us, but decided not to have protected sex within perceived seroconcordant contacts? So when you think your partner's negative and you're negative, you don't use condoms. You see a similar crossover, but it happens much sooner. So basically, if men started having more partners in Seattle, the effect would go away more quickly. Okay, so now let's look more closely at a sensitivity around condom use. Up here, it's hard to read. This is condom use in perceived discordant contacts, and this is condom use in perceived concordant contacts. In our model, men in discordant contacts, where one is negative, one is positive, use condoms about 30% of the time. It's really interesting, actually, when I came across these, I was confused at first, but men in perceived concordant contacts use condoms more often, about 50% of the time. And I think that's a selectivity of risk thing. That's what maybe Steve was telling me. Anyway, so that's the baseline. So remember, 16% here, 16% here. What happens if in perceived discordant contacts you don't let anyone use condoms or you make everyone use condoms? What happens to the effect of serosorting? And as you can see, there isn't really much effect. You get about an 8% drop in HIV prevalence at the baseline rates of condom use, but even if everybody used condoms within the serodiscordant contacts, you would still get about an 8% benefit. However, in perceived concordant contacts, where people think that they're having a partner who has the same HIV status as them, the more that they use condoms, the bigger the protective effect of serosorting, which makes sense. Here it's about 8%. If everyone used condoms, it goes to about 12%. If nobody used condoms in these partnerships, you still get a slight benefit of serosorting. Remember, this is in Seattle with the high rates of testing, as you mentioned earlier. And so here's my last slide for the results. Testing in our data, high activity men test more often because probably of perceived risk. They test on average 2 times a year, which is about every 6 months. Low activity men test about once a year. So this is the baseline, the 16 and 24. This is serosorting scenarios, this is no serosorting scenarios. What you see here is when you decrease the frequency of testing, so here low activity men test every 5 years, and high activity men test every 2.5 years. The direction of the effect of serosorting is opposite. Or you don't have a difference, right? Actually, I didn't test the significance between that. But so basically, the theme is the less and less you test, these bars start to change the directions. And we didn't explicitly model the proportion of, I always have to think through this when I say it, the proportion of positive men who are undiagnosed is directly, of course, correlated with the frequency of testing. The other paper that came out within weeks of our paper said if the proportion of men who are positive and undiagnosed is 20% or higher, serosorting is a detrimental strategy. When men in Seattle test about this much, the proportion of positive men who are undiagnosed is about 12, 13, 14%. So it's actually that our 2 papers have similar conclusions. We just looked at it in different ways. When men test less frequently, that proportion, of course, increases. There was a MMWR paper that came out last year that surveyed men from like sex venues and bars. And they found that in Seattle, and they tested men in these venues. Men in Seattle had about 10 to 20% were undiagnosed positives, whereas in Baltimore and DC, that proportion was more like 40%. So that it makes sense if you try to think about both of our papers. Okay, so let's finish up. HIV prevalence among MSM in Seattle would be higher if men did not serosort, according to our model. But serosorting increases the proportion of infections, maybe not the absolute number, but the proportion of infections transmitted from undiagnosed men. Serosorting may not be as protective if men have a higher average contact rate. Condom use in perceived concordant partnerships increases the protective benefit of serosorting. And lastly, serosorting may be actually a detrimental strategy if men do not test often. So really, our main finding of this paper is that the recognition of serosorting should promote the more frequent HIV testing. I wouldn't go to a health department and say you should promote serosorting as a standalone prevention intervention. That wouldn't make sense. But maybe if you package it with more frequent testing, if men are doing it anyway, condom use, more frequent testing. A few things that we didn't include in our model, and I'm sure you can think of more, but we didn't include misrepresentation of serostatus. This would probably reduce the protective effect of serosorting if men lied about their status. And in our data, it happened occasionally that men reported to the survey that they had lied previously in order to have sex with a partner. Not that often, but it happened. Motivation for testing. In our test, men test on average every 6 months or 1 year. But in reality, men probably test a month after, if they're not feeling well, if they recently had unprotected sex, or they test every year at regular intervals. Our model doesn't explicitly use that. It's that kind of exponential decline that we talked about yesterday. Yeah?
So when people are misrepresenting their status, it's not just HIV positive men that are saying that they're negative, it's HIV negative men that are saying they're positive. Do you think that is, do you think some proportion of that is due to like a misunderstanding of their diagnosis, or did they say, no, actually, I deliberately misinformed my partner?
I don't know the answer to that.
Because
Do
I mean,
you
I
have anything?
question how many men would say they had an HIV positive status if they had received a negative?
Yeah,
I'm
not
sure.
often.
Yeah, I don't think that happens much. There is a paper, I can't remember which paper it is now, but they found that guys would report, they would purport to be negative to their partners. A lot of the times the guys who were positive would say, yeah, my last test was negative, but their last test was 5 years ago. And they'd been having unprotected sex since.
Mm-hmm.
So, you know,
Mm-hmm.
you'd way past the shelf life on those negative test results.
Mm-hmm. Mm-hmm.
That would reduce your positive.
Right.
In fact, and it wouldn't be deliberate misrepresentation.
Right. Right.
Well,
Yeah.
there's also the unfortunate thing of bug chasing people who, for one reason or another, would deliberately.
I
But
think
that
that's
is
the
so
Mexican
rare.
sewer rat,
I think
yeah.
that's pretty
I
rare.
think it's so rare, you know, where someone might misrepresent themselves as negative to deliberately get HIV. You know, you can find that online, but I don't think that's very common.
Mm-hmm.
And to misrepresent yourself as positive, I think would even be less common.
Probably someone has one.
Mm-hmm. I'm sorry, I just realized I forgot to repeat the questions when they asked them. Okay. So I'll try to do that if there are any more questions. Yeah.
I was wondering, in the model, does the increased testing presumably would increase treatment? And in the model, are they, you know, linked? That wasn't, you didn't say that explicitly, but I assume they are.
Right, because the more people that are in those second row of boxes which represent the people who are diagnosed positive, the more they can then flow to the third row of boxes which were treated. It's a proportion of men who are diagnosed flow into the treated category. So if it's 100 men and 60% flow in, that's 60. If it's 200 men and 60% flow in, then it's 120. So if that makes sense.
Would it be that low that people would be diagnosed and not, their CD4 counts falling and they refuse treatment?
I just threw that number out of the hat. The data on the rate of going on treatment and the rate of withdrawing from treatment is in the model. And I don't have it on the top of my head, but it's in there, yeah. I think that's the last slide, right. So I just wanted to acknowledge my co-authors. As I said earlier, this project came out of a collaboration between the UW Center for AIDS Research and the Public Health Seattle-Lincoln County Health Department. And Bob Wood was the outgoing director of the HIV/AIDS department. Matt Golden is the ingoing director. And we have a group in Seattle that it's basically a modeling group. So I wanted to thank them, as well as my co-authors and Martina Morris as well. So thank you so much.